Hi, I'm Deborah Simmons. I'm a critical care clinical nurse specialist and also a patient safety researcher, and I'd like to talk to you today about making safe enteral tubing connections. For our objectives today, we'll discuss how tubing misconnections occur, we'll identify some safety concerns associated with tubing connections, and we'll identify best practices for safe enteral feeding at the patient bedside. Florence Nightingale back in 1863 identified that actually our first principle is to require that a hospital should not harm the patient, which has been hard for us to understand even today when the Institute of Medicine came out with a report To Err is Human in 2000 that talked about 98,000 hospitalized Americans dying each year as a result of errors in their care. The Institute of Medicine also said that healthcare is built as a set of systems, a set of interacting elements that achieve the aim of healthcare, and errors are usually due to a convergence of multiple contributing factors in those systems, so that prevention requires a systems approach. This is a model of a systems failure in action. This was posited by James Reason, who says that errors in healthcare often follow as a result of failed defenses. He considers that a defense mechanism is like a slice of Swiss cheese, that it actually stands there as a barrier, but it has certain holes in it, and when those holes through the defense mechanisms line up, an error goes through to the patient. In this particular model that you have in front of you, we consider that errors are underreported, and that probably is one of the holes in our defense system. If we knew more about them, we would be able to prevent them better. We also recognize that organizations don't often anticipate the danger of common connectors. This information is gotten more prevalent in the literature. I think nurses are becoming more aware of it, but if you don't anticipate that danger, you're not able to prevent it for your patient. Now let's look at a systems view of nursing, and especially nurses' role in preventing errors. Van der Schaaf said that all of us work in situations where we have many factors that go into creating an error. Those factors could be organizational, they could be technical, or they could be a human factor, and we're going to talk a lot more about human factors as we go through this. All of those converge into a dangerous situation. If we have a dangerous situation that we recognize, we build an adequate defense mechanism so we don't have the danger. An example of that might be double checks on high-risk medications, or even checking twice that you've got the right consent form for the right procedure, or making a timeout in the OR. All of those are defense mechanisms that return us to normal and everything's okay. But if we don't have a defense mechanism, we're going to have a developing error. And when that happens, usually the nurse at the bedside is the last defense mechanism in place before the error goes through. And if the nurse catches it and it doesn't affect the patient, then we know that we've got a near miss. But if the nurse is not able to catch it, then we've got an error. And we consider that an inadequate defense mechanism. So our goal is to have defense mechanisms against errors so we can catch them before they reach our patients. And this is the view of our system in place in our work environment. If you think about it, by Van der Schaaf, he talks about the organizational issues, which would be the organization's decision to have an intensive care that looks like this. It has the technical issues, which would be all the technical components you see here, our monitors, our infusion devices, and even the blood pressure cuff and a ventilator. And also the human factor would be our interaction with this system and how we're able to navigate these in order to give good patient care. Connecting tubing in healthcare should be considered a high-risk activity because infusion and monitoring systems in healthcare are physiologically just not compatible. Many of them would cause death if they were accidentally connected to another. For example, you would never want to connect a gas system to a liquid system because we know that would cause death. And unfortunately, most of our infusion systems and our other systems for monitoring rely upon a single universal connector, and that is called a Luer tip, Luer lock sometimes, but it is a small bore connector, and they are universally compatible with each other. The problem with that is that routine tasks, such as connecting tubing, are at risk then for what we call an automatic mode error. And we'll talk a little bit more about that when we go forward. There have been multiple alerts from safety organizations regarding tubing misconnections. If you go to the Institute for Safe Medication Practices site, you will see that there was one that came out in 2001, 2003, 4, 5, and 6. And in fact, the FDA most recently in 2005 had an alert come out, and recently in 2008 has issued a calendar about tubing misconnections. ECRI Institute in 1986 identified universal connectors as a problem in healthcare, and in 2006 reissued that report. In the United States, the Association for Advancement of Medical Instrumentation passed a standard in 1996 with specific guidelines for our feeding tubes that said they should not be Luer lock compatible. And that standard was renewed again in 2005. There is a committee working on that revision again today, trying to find an answer for Luer lock incompatible feeding tubes. The American Nurses Association has passed a resolution that supports this standard, and in 2011, California legislation called for no further feeding tubes that were Luer lock compatible. That has been changed now to 2014, but you can see by all these efforts that people are trying to solve the persistent problem. The Joint Commission, actually then it was the Joint Commission of Accreditation, has issued an alert, issue number 36, which was a sentinel event alert that said tubing misconnections were persistent and potentially a deadly occurrence. And even in Europe we see that the International Organization for Standardization in Paris in 2006 worked with AAMI in order to enforce the standard. They will be continuing that work to date. They have many examples in the international literature where we have oral medications that were accidentally given through intravenous lines, or enteral feeding that actually went down a Hickman line in error and had problems with oral cyclosporin giving IV and central lines. So we see that's not just a problem in the United States. The United States Pharmacopoeia found more than 300 cases in the MedMarks database of different tubing misconnections that had occurred and been reported. These are some of the examples that they found. If you were to look at a review of the published literature around tubing misconnections, you would find that in 1972 it was identified that the connectors were a problem. That was done by Wallace. And this is a timeline of tubing misconnections in the literature that we have seen.